community radio station, broadcasted on 106.2 FM, and we are on LRB Digital Network, which is broadcasting in Leicester and London. Absolutely fabulous to have you all here today, and it's an absolute honour to have this show. We've been having some very distinguished guests over the last few weeks, and indeed we are going to continue the trend because our guest this week is also very special indeed. I hope that you've all been well and healthy. Children, message for you, it's the last week of half term. Just give it all your best. I know you're very tired, and then next week you can chill out and do what you do. Remain healthy, get out and do some exercise, no Xboxes, no going on digital media, or no watching the television like I've kept my kids plastered at home. The fact of the matter is we all need to know how to be healthy, and this is the doctor's advice. So, my dear listeners, wonderful show we have today. I hope that you're all tuning in. As usual, it would be wonderful to have your participation, and you can ring us on the studio telephone number, which is 01733 602 133, or you can text and WhatsApp us on 07745 278 978. Or alternatively, you can watch us on the Facebook live video by liking the Salaam radio page and share the video. It's a good resource of education so that you can let people know, because I tell you, this topic that we are going to be talking about, first of all, we've got one of the best in the profession on the show today. I am very honoured to have my guest on the show, and I'll give you a little bit of intro about him before I say hello to him. And we are going to be talking about skin-related disorders, and I will tell you exactly what we're talking about. But let me give you a bit of an intro on my wonderful guest, who is Dr. Anton Alexandrov, who is a consultant dermatologist and honorary senior lecturer at De Montfort University, Leicester, Spire Hospital, at the Leicester Nuffield Health Hospital, Cambridge Nuffield Health Hospital, and Bedford BMI Manor Hospital. He clinically trained in the United Kingdom and has worked in the UK since 1999 at major NHS teaching hospitals in Cambridge, Newcastle, Nottingham and Leicester, so has worked all over the country. And he began his research career with a PhD at Edinburgh University in 1991 in the field of cancer immunology, and has since published over 40 peer-reviewed research papers and reviews. He continues to believe that research is very important, which I think is very important, completely agree with him, as it widens clinicians' horizons and contributes to improving patient care. Hello and good evening, Dr. Alexandrov.
Hello, thank you very much for inviting me, much appreciated.
Yes, it's absolutely wonderful to have somebody of your level of expertise on the Body Health and Mind show for Salaam Radio, so thank you very much for that. And I believe that, Dr. Alexandrov, the dedication that you display actually is demonstrated in the fact that you are still in your clinic, aren't you?
Correct, yes, absolutely. Still in Spire Hospital.
Right, so your day hasn't ended yet, and that goes to show the level of dedication you have to your patients, and we are going to demonstrate that, which is wonderful. So if you've just joined in the conversation, this is Dr. Shabina Sudkayum on Body Health and Mind Show. Text and WhatsApp us on 07745278978. Call in like you usually do, 01733 602 133, or ask us questions on Facebook Live. We would be very happy to answer any of your questions. So, listeners, today I have been chatting with Dr. Alexandrov beforehand, and we've had some exciting conversations actually regarding a few of the conditions that I said that we would be talking about. And three of the conditions that I think that we'd like to discuss are about eczema, psoriasis, and vitiligo, which we will talk about in greater detail. But Dr. Alexandrov, talking about, obviously, before we go on to these conditions, tell me a little bit about yourself. What created your interest to become a dermatologist? We all go through medical school and then we all skew off to a particular speciality. What motivated you to become interested in dermatology?
Thank you very much. It's because there's such a big, diverse specialty, over 2,000 different skin conditions.
Yes.
I think this is the attraction, because so many different conditions. And also you can see so many people, you can help to so many people as well.
Yes.
And it ranges from, well, it seems to be trivial like acne or eczema until patient have this condition, when it becomes a major issue. So
Yes.
something which is like skin cancer is very important as well. So
Yes.
very big range, and you can actually see and help a lot of people.
That's right. I think skin cancer is definitely a show that I would like to talk about further ahead, because cancer, as we know, is on the rise. And Dr. Alexandrov, obviously, in terms of being a general practitioner myself and seeing many patients, we do have a GP online forum where we will sometimes, with consent of the patients, post up pictures and talk about a funny rash. So it is very comforting that we have somebody of your expertise who is able to give us a bit of familiarity and insight onto these various skin conditions. And today I'd like for us to discuss and let our listeners, give them a bit of insight and information on the condition of eczema. Now, how does eczema actually happen? We know it's due to dry skin, but I'm actually seeing a lot of it on the increase in very, very young children. What is the process behind the development of eczema, Dr. Alexandrov?
For a different way theories, but it is believed, excuse me, my husky voice,
No.
I'm a bit cold, but it's believed that it's a skin barrier, a problem.
Okay.
And part of it is genetic, so it happens more often in people with asthma and hay fever. It's called atopy. But the problem is a skin barrier. Skin barrier in patients with eczema is not as good as in patients without eczema or other people. And therefore, allergens penetrate easier and then make skin more inflamed easier.
Right.
Whereas things like filaggrin, for example, identified, other genes are not identified. But I think the main problem is the skin barrier. And I absolutely agree with you. It's 1 in 3 children locally now affected by eczema.
Right, that's absolutely right. I have 4 children. One of them, the first one, my eldest, she was diagnosed with eczema, very, very young age actually. And being a clinician myself, it was very frightening to have a look at it. And could you explain to our listeners what you actually mean by the word it's a barrier problem? What does that actually mean?
Well, skin is a natural barrier which keeps microbes and generally allergen away from our body, from our bloodstream and inside the body.
Okay.
But the skin is very important because this is the barrier. And it is designed to keep the things which we don't need outside of the body. But unfortunately, sometimes it doesn't work very well. And therefore, it allows some chemicals or microbes to penetrate the skin and get inside the body and interact with the immune system.
Right, okay. So the belief is that skin being a barrier allows for the entrance of microbes or other particles to enter the skin and then cause an inflammatory reaction. Would I be correct in saying that?
Yes, absolutely correct. In cases when it doesn't work as well as it should, and this causes generally dermatitis.
Okay. I was always of the impression, being a clinician, that it would be caused by a lot of people blame high perfume products with chemicals in them, etc., irritating the skin surface. But this has given a completely different perspective, actually, to my understanding of it. So children that are born usually...
You're not there are some delicate sides to it, and there are some more complex issues to here. You see, we talk about the dermatitis, eczema. Dermatitis and eczema are the same, effectively. It's the same, just different names. And then if we talk about eczema, let's say, atopic eczema, which comes from inside, so people believe it's a genetic predisposition, then in general, it's not caused by a particular allergen or irritant. It allows to penetrate the skin a potential allergen which we don't know much about it. But there are other types of eczema. One is called allergic contact dermatitis.
Okay.
And this is when people develop allergy to particular chemicals, let's say perfumes or a particular perfume. And then they would react to very, very small amounts of this perfume, which most people wouldn't. And they would be very sensitive to this particular perfume, let's say. And this is called allergic contact dermatitis. And this type of reaction can be identified by a test called patch testing.
Okay.
Different chemicals, about 70 different chemicals, common allergens, would be applied on the back of a person under aluminium discs for 48 hours.
Right.
And if a particular chemical would cause a patch of eczema,
Okay.
then this person would be allergic to this particular chemical.
That's
And,
correct.
and the treatment would be to avoid this particular chemical. So read all small print on all household products and so on to avoid this particular chemicals because everything now labeled.
Right.
The other type contact dermatitis called irritant contact dermatitis. And just an example, if a person would put his hands or her hands into petrol a few times a day,
Right.
after a week or two, he would develop dermatitis.
Right.
And this is a common reaction. A majority of people in this situation, majority of patients in this situation would develop contact dermatitis. And this is called irritant contact dermatitis. So it's not to a particular specific chemical, but due to irritation to non-irritant chemicals. And this is commonly seen in people who do a lot of wet work. For example, doctors, nurses who wash hands all the time between patients, surgeons who have to scrub their hands, hairdressers, waitresses, what kind of stuff.
Okay. So when we talk about small children, obviously, little babies, up until what age? Because we get patients that come in and ask us for patch testing to be done. Under what age are children actually not advised to have patch testing done to identify an allergen?
It's a technical question. Generally, you can do patch testing at any time, but from technical point of view, there are 70 chemicals in the standard battery.
Right.
And this is just about enough space on the back of the adult to get them on. In children, you have to decide which one to test and which one not to test, because physically their bags are smaller. So it becomes a technical problem. We do patch test children sometimes when we really got stuck, but we have to decide what allergen to test. So it becomes challenging problem from technical point of view.
Right. Yes, I can imagine. And so you have a child that's born, obviously, and what would be your advice to maintain a good, healthy skin regime for those children so that they don't actually become exposed to that allergen or irritant? Is it to bathe them with plain water or to put something in the bathing agent, given that our water is quite chemically treated in this part of the UK, isn't it?
There are some, yes, there is more to this as well about the water, but in general, I would say a good approach would be to avoid soaps in general and shower gels.
Okay.
And to add into the bathing water bath oils.
Okay.
There are a lot of them, and common things would be things like hydromol bath additive for bath oil, Olatum bath oil, Avena bath oil. There is a range of them.
Okay.
But these are moisturizers because water itself, in a paradoxical way, dries skin. Soap will dry it even more. So you need not just water, but a bath oil added to it.
Right.
In addition, what we do for children in whom there is eczema, we also use moisturizing ointments instead of soaps or shower gels to actually wash with.
That's right.
Yes, as you, for example, take hydromol ointment, for example, or cetrapan ointment, and just love it under water, it becomes soapy. So this is excellent soap substitute.
Right.
And this we would advise in children who are actually affected by dermatitis.
Yes, that's right. Now, what are your views on proprietary, bought over-the-counter, perfumed products like Johnson's or, say, from supermarket chains, etc.? Would you advise that these are not suitable for newborn babies because the hospitals all have them and they bathe the babies as soon as they're born sometimes in many instances? Would you advise using against them?
I generally, yes, you see, perfumes can irritate skin in general terms. So I'm not sure if babies can appreciate the smells in a bath, and I'm sure we can appreciate smells outside the bath as well in such case. So I personally would start thinking about using non-scented products like usual bath oils and moisturizing, let's say, ointments such as hydromol or cetraban or similar, Epiderm.
Right, epiderm. Yeah, that's quite thick and waxy, isn't it? So
It is,
it's
but if you love it in water, it becomes much less thick and is excellent substitute. And we don't have perfumes either,
oh, that's
so it's
wonderful.
an advantage. Yes.
So I've learned something new here. So epiderm, really, I've used it a lot when I go to see people who are quite elderly and have quite irritated skin, and I say just slap some epiderm on, but actually to use it as a soap substitute as well is quite enlightening. So for the listeners that are listening in, Dr. Anton Alexandrov we have with us, consultant dermatologist from Leicester and Cambridge, who is giving us an insight into the condition of eczema. And his advice so far, obviously, as you've heard just now, has been to not to buy your proprietary over-the-counter soaps, gels, etc. that are used to bathe little babies, but more to use bath oils. And some of the examples he's given are obviously Aveeno, Oilatum, and to use that inside, and also to use some type of a cleansing agent. And that can be done in the way of hydromol, which is sort of a thick, waxy substance, but it's very good for washing once you put it into the bath, and it can lather up, etc. And the process of eczema is pretty much about an allergen or even a bit of bacteria entering into the skin and setting off what you call an inflammatory reaction, which makes the skin irritable and then can lead down to a pathway of irritable, itchy skin. Now, it's very hard work, isn't it, Dr. Alexandrov? As I learnt with my daughter once she developed eczema, about some emollients or some moisturizers don't really suit everyone, and it's about trying to find the right moisturizing agent. And could you give some advice to our listeners in terms of what they need to do if you've had a diagnosis of eczema, what the regimen should be? Should they bath daily? What advice would you give them?
Okay, well, I think moisturizers as often as possible.
Okay.
Ideally, greasy moisturizers, but some people just do not like greasy moisturizers, can put up with this. If there is no point to use something greasy if you're not going to put it on your skin.
Yeah.
So something which you feel comfortable with,
Yeah.
but within this range, greasy better than less greasy.
Okay.
The other thing is that sometimes very greasy ointments, although they are good in longer term, in shorter term, immediately they can make skin quite hot and itch. So if this happens, you can have a lotion or a cream, let's say, Cetraban cream or Hydromol cream, which is not ointment, or, for example, Balneum Plus cream.
Okay.
You put in the fridge, so it's chilled, and if you apply chilled cream, then you get instant relief, and it can help you with the, for the next half an hour or so.
That's great.
Important.
Okay, and is there any evidence that says, and this is sometimes I've said to my patients, that it's important, obviously it's hard work, so you can cream at least twice a day, I usually say to them. And is there any evidence in saying that you cream in one direction only because eczema spreads? Is that right? Is there any evidence behind that?
No, I don't think this is the issue here. So eczema, you cannot spread eczema by itself. Eczema spreads if you're undertreated.
Okay.
Sometimes it can be just difficult to treat eczema and therefore it spreads, but it doesn't really depend on how you treat it. We only think about the direction. If you use greasy moisturizer like ointment, rub it against hair follicles, against the grain, then you can potentially block the hair follicles, and it can give to the spots around hair follicles folliculitis.
Right.
The advice is go along the grain, not direct the grain, so don't rub the ointment against the grain.
Okay.
Smooth it along the hair follicles.
Okay, so smooth it along the hair follicles and not against it, because you have the risk of bacteria entering the pores, which could then make, obviously cause an infection and irritation. That makes sense, I think. And in terms of steroids, because we're coming to this now, where you see that emollients aren't doing enough and now you've got irritation of the skin. Sort of, we know that a lot of people use steroids to try and dampen down the initial inflammation that occurs with eczema. But could you give our listeners a bit of insight into the long-term effects of using steroids? Because I often get patients who will come to me and say, well, we need Betnovate or we need Dermovate, and this is the only thing that's going to work for us. And apparently at the time you see the skin, it looks okay, doesn't look too bad, but I do get patients who are quite persistent on saying, well, no, this is the only steroid that works for me, so I want that. What would be your advice for such patients?
Very difficult to give the general advice because patients should follow doctor's advice on which steroid use for what duration and on what part of the body.
Sure.
For example, the skin on face and skin fold areas like armpits or behind knees are thinner, so we have to use a less potent steroid cream ointment, whereas on the scalp and on the hands and feet, soles and palms, the skin is thicker, so you can use stronger, more potent topical steroid. Again, in children, the skin is thinner, so we use less potent topical steroids.
Right.
Therefore, patients should really speak to their GP or dermatologist about how long and what particular steroid on what particular part of the body we should use. In this case, it would be safe. But sometimes, for example, Dermavate is the strongest one.
Yeah.
You have to use it on the body all the time. It's obviously, you can use it for a short period of time, maybe for a month or two, let's say in adult on the arms and legs, but not in the skin fold areas.
Right.
But we can use it continuously. There are other options which we use less frequently, but might be suitable for them. For example, sunlight, special sunlight treatment, phototherapy, we call it, UVB phototherapy, or even tablet treatments.
Right.
For example, for hand dermatitis, there is excellent tablet called Tactina, which is now available more recently.
Okay.
And for severe general dermatitis, I say about 1 in 20 people or less may require very strong medicines such as azathioprine or cyclosporin, or even injections. This year we should get first injection for atopic dermatitis in the NHS.
Okay, wow. Now, you talk about light therapy. I am aware of somebody who has very severe eczema, and it's a vicious circle, moisturizing, putting steroids on. Is this something that you advocate, like PUVA light therapy for patients with eczema dermatitis? And does it work?
It would be the next step. So in addition to steroid creams, we also have non-steroid creams, which also help with overactivated immune system. Creams such as Elidel or protopic ointment. Yeah. So if people use too much steroid creams, it could be alternative, or it can be used in combination in particular cases. But if topical treatments are not enough, the next usual step would be UVB phototherapy. Okay. And it depends. It would generally be helpful to majority of patients, but a lot of patients cannot find time because you have to attend twice a week or 3 times a week for something like 2-3 months. Right. And a lot of patients cannot take time off work, or they don't want to miss school, for example.
That's right. Yeah. How long does the course actually take? So 2-3 months, and how effective is it?
It is very effective usually in people with psoriasis. And in psoriasis, it would be like 6 weeks is enough, sometimes 2 months. Right. It works not so well in dermatitis, but reasonably well in dermatitis. Okay. It takes longer. We talk about 2-3 months in dermatitis. Right. It can work in some people with vitiligo, but it usually takes much longer. We're talking about 6 months with vitiligo on average, or even longer.
Okay, wow. Well, that's very interesting information. Before we've got probably a minute and a half before a break. Would you use that minute and a half, please, Dr. Alexandrov, to explain to our patients the long-term effects of using steroids and the dangers of using steroids, please?
Okay, if patients overuse steroid creams, and in my practice we usually underuse, but there are obviously patients, and I saw them, who overused it. The danger is that it can cause so-called skin atrophy. It's thinning of the skin. Okay. It looks like stretch marks in pregnant ladies on tummies, on abdomen. But unfortunately, it can happen where the steroid creams or ointments are overused in particular areas. and unfortunately, it's irreversible. Once it's happened, there is no way to go back. So it's very important to follow exact instructions of your doctor, whether it's GP or dermatologist.
Okay, well, that's wonderful, Dr. Alexandrov. So we're approaching a break now, listeners. This is Dr. Alexandrov from Cambridge and Leicester, who has joined us today. We're talking about eczema, psoriasis, and vitiligo. Don't forget to join us after the break. We've got a 4-minute break. Don't forget to join us after the break, where we will be talking more about this on the Body, Health and Mind Show and on LRB Digital Network.
الله أكبر الله أكبر الله أكبر الله أكبر أشهد أن لا إله إلا الله أشهد أن لا إله إلا الله أشهد أن محمدًا رسول أشهد أن محمدًا رسول الله حي على الصلاة حي على الصلاة حي على الفلاح حي على الفلاح الله أكبر الله أكبر لا إله إلا الله
الله أكبر الله أكبر لا إله إلا الله. اللهم صل على محمد وعلى آل محمد كما صليت على إبراهيم وعلى آل إبراهيم وبارك على محمد وعلى آل محمد كما باركت على إبراهيم وعلى آل إبراهيم في العالمين إنك حميد مجيد.
So it's this and this, right?
اللهم آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. اللهم بك نحيا وبك نموت وإليك المصير. رضينا بالله ربا وبالإسلام دينا وبمحمد صلى الله عليه وسلم نبيا ورسولا.
بسم الله الرحمن الرحيم. تبت يدا أبي لهب وتب ما أغنى عنه ماله وما كسب سيصلى نارا ذات لهب وامرأته حمالة الحطب في جيدها حبل من مسد.
This is Salaam Radio, Peterborough's Muslim. This is Salaam Radio, Peterborough's Muslim Community Radio, broadcasting on 106.2 FM and online.
Welcome back. This is Dr. Shabina Asad Qayyum for your very own Salaam Radio on Peterborough's only community radio station, broadcasted on 106.2 FM and online. And we are also broadcasting LRB Digital Network. Wonderful show that we've got at the moment with Dr. Alexandrov, Anton Alexandrov, who works, consultant dermatologist who works in both Cambridge and Leicester. And we were having a very interesting conversation about eczema. We're going to be talking about psoriasis and vitiligo. And Dr. Alexandrov, are you still with us?
Yes, and I just got the admitting rights on the Harley Street as well, just to add to the list.
Oh,
but I'm here.
Wonderful. Thank you very, very much. Yes, so he actually practices in Harley Street in London, a very famous Harley Street. And I'm sure that a lot of medics that like to practice have a dream of practicing on Harley Street. So he's a very big name and very, very qualified in his field. And if you'd like to join in, feel free to call us on the studio telephone number 01733 602 133 or text and WhatsApp us on 07745 278 978. Or you could ask us a question on Facebook Live, and we indeed do have many people who have joined us on Facebook Live, which is wonderful to see. So thank you very much for all tuning in. Now, Dr. Alexandrov, I do have a question for you. It's from a sister Farzana, and she has said that she has very severe eczema on the face. She has been given mometasone, which is one of the strongest steroids that there is, but she is finding that it's not really controlling her eczema. She is asking, is light therapy something that would be suitable for me?
Yes, I think light therapy sounds the next sensible step.
Okay.
Mometasone, it's not usually used for long periods of time on the face because it's too strong. It can be used for a short period of time, let's say a week or two, but usually after that needs to be something else. There are some creams which are not steroid, which sometimes can work,
Okay.
but it sounds like she needs to move on to the next step, which would be light treatment or even medicines.
Okay, so the medicines you spoke of at the beginning, Sister Farzan, at the beginning, Dr. Alexandrov told us about non-steroid medications that were protopic. And what was the other one that you spoke of, Dr. Alexandrov?
They're quite similar. They're not steroids. They can be used on the face or skin fold areas for quite a long time, intermittently.
Okay.
Now I think if it is on the face and difficult to treat, sometimes I think about allergic contact dermatitis to see if eczema can be caused by allergy, if a person developed allergy to something. And in such case, patch testing can be useful, allergy test.
Right, okay. So it could also be patch testing. And I've also actually got another question over here. Sister Farzana, I hope that answers your question. If you already haven't had allergy testing done, Dr. Alexandrov is sort of suggests that to you. And the options are that, yes, you could be a candidate for light therapy, but also using some non-steroid type of medications like Protopic or Eladin that he has spoken of. And we've also got a brother Adil over here. Brother Adil says that, hello there, I am from London. I normally have, again, it's a facial eczema question. I normally have eczema on the face and nothing works but Fusibet. And my doctors don't want to give it to me anymore.
Yeah, that again is a quite strong one. And again, it's not advisable to use it for long periods of time on face.
I see.
But it's too strong. And it can cause, if it overused on face, can cause skin atrophy, which we talked about.
Right, so skin atrophy is thinning of the skin. And Brother Adil, who's spoken to us from London, the fact of the matter is that, yes, it's probably time to look at some other therapy for you or some treatment. My question to you is on the back of what Mr. Adil has asked us, Dr. Alexandrov, is Fusibet being a combination of an antibiotic mixed with a steroid, was it only used in sort of infective dermatitis or infective skin conditions?
Generally, yes, it's used for this purpose. The difficulty here is that dermatitis, because it interacts with skin barrier, quite often is accompanied by infection.
Right.
Sometimes more overt, sometimes less overt. The uncertainty here is whether infection actually drives eczema or whether it's just there because there is dermatitis eczema. We just completed a trial in Nottingham in babies, and what we showed in babies with atopic dermatitis, if you use antimicrobial treatment, it makes no difference on the treatment of eczema if you treat eczema with appropriate steroid creams. So if you treat eczema and suppress inflammation, whether there is infection or there is no infection, the outcome is the same.
Oh.
It may be different in adults. We don't know. We haven't done such study. The study hasn't been published yet. It's being prepared for publication.
Okay.
But it appears that at least in babies, if you treat eczema itself, it doesn't really matter if there is infection there or not.
Right. Okay.
It's very new.
Yeah, that's very, very new finding, actually. So, listeners, if you have listened to a lot of what we've been talking about eczema, and eczema is a big topic. I think sometimes you need a whole show to talk about eczema. But there has been a lot of information that's given to us by Dr. Alexandrov, and it sort of more focuses on the fact that it's a dermatitis type of process that takes place in the skin. A lot of hard work is needed, so it's about applying moisturizers, greasy moisturizers, if we're to talk about it in summary, twice a day at least, and to use a steroid, as Dr. Alexandrov has said, as sparingly as you possibly can, but where you see that steroids actually aren't working, then to possibly be referred to a dermatologist for consideration of non-steroid medication or light therapy. Light therapy obviously involves a lot of commitment, in which twice a week, and depending upon the condition, it can take even up to 6 months. Something like vitiligo, for example, which we're going to be talking about next, because I find vitiligo is one of my weak areas. It's not it's something that is of my forte as a GP. And if I do see somebody that comes to me with a white patch on their skin, and you look at it and you think this is vitiligo, I really do get stuck, because it's horrible for wake up in the morning and see that you've got a white patch and it could spread. Could you tell our listeners, Dr. Alexandrov, how vitiligo actually starts? What's the process behind it?
Same as psoriasis and eczema, it's the result of the immune system of the body, which usually fights infection, and not working properly, so overactivated in a particular direction.
Right.
Of this matter, in asthma and diabetes, it happens the same as the immune system, which gets out of the control. In the case of vitiligo, the immune system starts to recognize cells which make pigment, as something foreign, and really seeks and destroys them.
Right.
It's a bit unpredictable. With vitiligo, it can stop, it can progress, it can regress. So it can get better by itself, it can just persist as it is, or it can get worse. So difficult to predict.
Okay.
There are some treatments which can be tried.
Okay.
It's not we don't have at present very good treatment, but excuse me.
Okay.
There is a couple of treatments which being tested right now at the late stage of the testing. It passed so-called phase 2 clinical trials.
Okay.
Phase 3 is being prepared worldwide, really. Initially, we wanted to use us as well in the hospital, but because of the Brexit, it looks like we pulled out of Great Britain.
Oh dear, yes.
But it doesn't really matter, because the tests are still going away in Europe, in America.
Okay.
The results will be available. The license in due course will be worldwide.
Okay.
And what we showed in the phase 2 clinical trials, these are very, very effective treatments, much better than we have to date.
Right.
So there is a very good hope that within a few years we will have a completely new and very effective treatment.
Okay, that's wonderful. And what does that treatment involve? What treatment is this that we were talking about?
We're trying 2 ways. It's the same chemical, but we're trying to use both topical treatment and oral treatment with the same chemical.
Right. Okay. And you were talking again about light therapy. So that's what's sort of in the trial. It's in a phase 2 trial. Currently, what treatments do we have for vitiligo?
Okay. If it's on body in adults, then strong steroid creams can be used for a reasonably short period of time.
Mm-hmm.
And then quite often we use non-steroid cream, which are licensed for eczema, but we can use it off-label. So Elidel and Protopic cream and ointment, we can use it to treat vitiligo. Vitiligo on face responds better to the treatment than vitiligo on hands and feet. So hands and feet are generally very difficult to treat. With this camouflage, you can see camouflage specialists who can teach you how to use special medical makeup to camouflage white patches. So sometimes this can be very helpful for both adults and children. But that's masking it rather than actually treating it. So from treatment point of view, quite often we use tacrolimus, also known as Protopic and Elidel. And UVB would be the second treatment. But UVB vitiligo can take a long time, can take 6 months or longer.
Right. So So UV therapy, which is light therapy, can take 6 months or longer. What is the effectiveness of light therapy on someone who has vitiligo? Especially because it's a very, I wouldn't say use the word disfiguring, but it's very unpleasant for the person that has it, especially on the face. What's the effectiveness of light therapy on vitiligo, Dr. Alexandrov?
It is by far not 100% effective, but it's worth trying because it's relatively safe treatment. Because we monitor how many treatments patients have, so at a certain point we will say you had enough, you shouldn't have more than that. So you shouldn't obviously do it by yourself in the tanning salons because it's a wrong type of light treatment, and nobody calibrates the tanning salon sunbaths, and you have no idea how much of UV you actually get. But in the hospital, it's quite safe because we monitor, we calibrate, we keep a record of how much UV person had. And it's worth trying. It works especially well for face. So it's certainly worth trying to do it.
Yeah, because the reason why I ask is a lot of our community belong to the Asian community, and obviously with us having a darker skin color than the Caucasian population, it is a lot more noticeable. And often people will go to their GP and the GP will say there is no cure for this, which is true in a way. There is no cure for it, but I think people would be interested in knowing an effective treatment to try and halt it in its process, because it's quite an unpleasant thing to look at, very worrying as well.
I would say it's Protopic, Elidel, and UVB treatment at present. But we really do expect this new breakthrough treatment within the next few years. It looks very promising so far. Of course, you have to do the late-stage clinical study and confirm the initial results. But in phase 2, which is quite reasonable, it looks very, very promising, much better than anything we had so far.
Right, okay, well that's brilliant, and it's very promising news for those patients of vitiligo. And I think if I refer to our conversation just before having the show, you did say that there are some exciting new treatments that we can talk about. So obviously we have brought that to the forefront. So thank you for obviously bringing that to our guest's attention. Now, because we're coming in the last phase of the show, I think that it would be really important to touch up a little bit about psoriasis, because psoriasis is something that doesn't necessarily happen at young age, is it? And what's the difference between, could you tell our listeners, Dr. Alexandrov, what psoriasis actually is and why does it occur?
It's another common inflammatory skin condition. For comparison, vitiligo probably affects about 1% of the population. Dermatitis, eczema, 1 in 3 children and about 1 in 10 adults. Psoriasis, it's quite big numbers. It's about 3-5% of population in England affected by psoriasis. All races and colors affected. It can affect people at any age, but it's quite rare in children. I would say it's either, there are 2 peaks, one in young adults, now in about 50s, 60s. And it's stronger when there is a stronger family history as well. So if we have brother or mother who has psoriasis, you're more likely to have psoriasis. If you have 2 people in the family, close family have psoriasis, you have even higher risk of psoriasis.
Right, okay.
But on positive side, we actually have a lot of treatments. It has been probably the most developed or developing area of dermatology regarding treatments. And practically we can keep anybody free from psoriasis at present.
Wow.
So we cure psoriasis, but effectively at present we can keep anybody free from psoriasis symptoms.
How would you do that?
Well, it depends. Majority of patients have very little psoriasis, bit of elbows and knees, maybe with a scalp, and they can get away using very simple treatments. For example, even moisturizers may be enough, or something stronger with vitamin D, something called Enstellar, for example,
Enstellar,
or
okay.
special shampoos. In people, however, it's more widespread. Light treatment, UVB works really well, and quite often people have UVB once a year to keep it in check, and then use topical treatments in between or alongside. However, in minority of patients, it's not enough. We're talking about probably about 5 to 10%. So like 1 in 10, 1 in 20 people who has to start thinking about medications.
Right.
Passion medications, which vary from the medication which act directly onto the skin, or medication which act primarily on the immune system or activate immune system, and with the tablet treatments. And we generally control psoriasis quite well, but you have to be careful to keep an eye on liver test, blood count, kidney test, blood pressure, and so on.
Yeah. Okay.
And sometimes they don't work. So for the last 10 years, a new type of medication called biologic has been developed.
Okay.
And we have about half a dozen of them, including one oral medication.
Okay.
And these injections, they are highly specialized. They have less side effects, but they're very expensive. We talk about 10,000 a year. For the tablet, we talk about 6,000 a year. So the government has to ration who can have it. And they're generally designed, rationed for the people with severe psoriasis.
Sure.
More than 10% of body surface affected, generally speaking, who has responded to the usual treatment, like light treatment or classical tablet treatments.
Right.
But using these treatments for people who are more severely affected by psoriasis, because we have a range of this treatment now, we can keep literally everybody free from psoriasis.
Right. Okay.
These resistance develop time to time, but when we have a choice of these treatments.
Yeah. I mean, it's rather sad, though, that in today's day and age, an era has developed whereby, and obviously the NHS is very cash-strapped, as we all know, that we have to ration patients, so only the ones that have really suffered, and obviously on their journeys of where they have developed a severe psoriasis, they would have gone through a considerable amount of suffering to get where they are, so that they can get a treatment, unless they want to pay privately and go down at that course, which then again is still very expensive, isn't it?
Absolutely, yes.
Yeah, so that's one of the things. And for the information of our patients, would you like to explain how long it actually takes for a flare-up of psoriasis to settle down if they're doing all of the right things?
I just thought about something. I do like to publicize the latest development in treatment of vitiligo, psoriasis, eczema. So I tend to tweet on my Twitter, your skin doctor, if somebody's interested. So I'll try to keep it... everybody updated on the latest development.
New developments, okay.
Yeah, new development. But coming back to your common treatments, let's say. But coming back to your question, with treatment, I think it can take between 2 and 6 weeks for flare psoriasis to come down.
Right.
I was depending how bad the flare is and how well it responds or how strong the treatment. So with creams, I would say it takes about 2 to 4 weeks to get better if it responds to creams. With light treatment, I would say about 4 to 6 weeks. With some potent medicines, it can get really well within, let's say, 2 to 4 weeks.
Right.
But for maximum effects, we're talking about probably about 3 months.
Okay, so we're talking about 3 months. And I'd like to ask this question because a lot of people say, and in some of our GP resources, it tells us that psoriasis can happen due to emotional stress as well. Is this true?
A very difficult question. A lot of my patients completely believe in this, and this is what we really think.
Okay.
It's difficult to prove scientifically, but it certainly appears to be in mice. So in mice you can prove it.
Okay.
Humans are not mice, so there is a
It
difference.
is a difference because humans obviously can relate and express. I've actually
Yes.
got a question here from a brother or sister. Thank you for a fantastic program. What's the best treatment to keep psoriasis of the ears and ear canals under control without using steroid ointments?
Difficult. My favorite would be very weak steroid ointment with a little bit anti-yeast agent called Dactacort or
Oh.
Canesten HC.
Okay.
Cold steroid is very, very weak. There is alternative. There is a cream, we talked about eczema, protopic,
Yeah.
and Elidel. So one is open now with cream,
Okay.
which is not licensed but can be used off-label in psoriasis. It can work really well on face, including ears. And then
Right.
after that, I'm afraid we're talking about powerful medicines.
Right, so we're talking about light therapy. So, brother or sister, thank you very much for your question and for your compliments as well on the show. So, the answer that Dr. Alexandrov has given you is that he would be in favor, without using steroids, you have asked, but he would be in favor of using a very, very weak steroid, preferably with Protopic, which is a non-steroid agent, or Elidel. But if that doesn't work, then we are looking at more stronger treatments. Is that correct?
This is correct, and these treatments generally are on prescription, so you have to get your GP or dermatologist to prescribe them for you.
Give them, because I do find, I think the brother or the sister is absolutely right. I've always found, because I've got sort of a specialist interest in nose throat surgery, I've always found that treating eczema of the ears is very, very tricky, Dr. Alexandrov. It really is.
Absolutely, and when it's very tricky, we start thinking about patch testing to see whether it could be allergy which keeps it going.
Right, so it could be an allergy as well that keeps it going. And the other thing is that I've also noticed that a lot of people that suffer from a condition which is known as seborrheic dermatitis of the scalp will also have this problem of dermatitis in the ears too, and it can get quite weepy.
Yes, absolutely correct, yes.
Right, so that's. I hope that that has answered your questions, brother or sister, and thank you very, very much for joining us on that. And basically what Dr. Alexandrov has said, we've got Dr. Alexandrov, consultant dermatologist, works at Harley Street, works in Cambridge, obviously a consultant at Leicester as well. And one of the important pieces of information, resources he's given us is that he keeps people up to date via his Twitter account, which is known as Your Skin Doctor. Is that right?
Yes.
Yep. Your Skin Doctor is his Twitter handle, and he keeps people abreast of the latest treatments that are being developed. And he's given recently a very, very important insight into a new development with psoriasis as well, and that a trial is now taking place. And with vitiligo as well, a trial is in its second phase, and it's very, very promising. And we were speaking about stress with regards to psoriasis, and it's a difficult question. It's been shown to be proven in mice, but I've seen in, obviously, following back after the question came in, following back to that question, Dr. Alexandrov, is that you do see people when they are quite sort of emotionally stressed, and this is the case with any illness, it's at that time that they tend to feel a lot more tired, their immunity system's down, they'll develop colds, coughs, not getting enough sleep. Could that be associated with a flare-up of psoriasis as well?
A lot of my patients are totally convinced in this. So they say, whenever I'm stressed, it comes and flares up. So a lot of my patients completely believe in this.
Okay. And what would you say with regards to diet? Is there any association with psoriasis and dairy, for example?
Very, very good question. Not generally with dairy. There is association with between acne spots and dairy and chocolate, but not psoriasis. However, there is a little bit of risk of psoriasis and heart attacks or strokes, especially in people with severe widespread psoriasis.
Wow, that's amazing. That's something I didn't know.
And therefore, healthy diet becomes important in general, and healthy lifestyle in patients with psoriasis, especially with severe, what we call widespread psoriasis. That becomes more important.
Okay.
And another thing, sometimes joints can be affected. So if patient have psoriasis, have joints affected, it can be quite serious. It needs to be probably investigated by the general practitioner or even rheumatologist.
Right. So that's obviously something that, we're definitely going to look into. Dr. Alexandrov, we've reached the end of our show. Like I always say every week, we don't realize this hour just passes by. I am so grateful to you that you've taken out your valuable time to inform the listeners that we've had in Leicester, London and Peterborough, and obviously nationwide and internationally as well, because we get a lot of listeners. So thank you very, very much for your time today. It's been wonderful, and I will be getting you on again, because this skin subject is something that's never going to end. We will always have problems with skin, etc. So thank you very, very much for your time.
Thank you so much. I'm very honored to be asked. So thank you very much indeed for your most kind invitation.
No worries at all. And hopefully we will get you back. So, yes, thank you. Thank you. Bye-bye. Bye-bye. So, listeners, this was the end of our show, and thank you very much for joining in, and come back next week for another show with Dr. Shabina Asad Qayyum on the Body, Health and Mind Show.